to the 15th episode of the Real Emergency Podcast. And today's theme day is Save a Life Day. And I think we can say with confidence that in the 2 years that we've been doing Real Emergency, we've helped you, the EMS clinician, maybe save some lives. That's what we're here to do. And we're so proud that we have thousands and thousands of views on our YouTube channel and countless more who are watching for continuing education credit on Prodigy. So for today's episode, which is our 15th episode, our panelists have each chosen a few clips from past episodes that they'd like to revisit and look back on. We'll be focusing on those clips that provided lots of value, both clinically and educationally. And we just want to remind you that Real Emergency is produced in partnership with Handtevy, ReelDx, and 410 Medical, and it's powered by Prodigy EMS. I'm Hillary Gates. I'm the Director of Educational Strategy for Prodigy EMS. All episodes are available to you for CAPC credit on Prodigy EMS. And for those of you watching live today who want to earn your 1 hour of CE, we'll have a QR code on the slides at the end that you can scan and direct you to the form to fill out to get your CE. Make sure you check us out on your favorite podcast platform or on the Real Emergency YouTube channel. And don't forget to follow and like us on Facebook and Twitter. Let me briefly introduce our resident experts. David Spiro is a pediatric emergency physician and professor at the University of Arkansas Medical System, and he's the Chief Medical Officer of ReelDx. Peter Handtevy is a pediatric emergency medicine physician, an EMS physician, and the founder of Pediatric Emergency Standards Incorporated. Mark Peel is a pediatric intensivist at WakeMed in Raleigh, North Carolina, and he's the medical director with WakeMed Mobile Critical Care. Dr. Peel is also founder and chief medical officer of 410 Medical. Finally, Zach Dunlap is a critical care paramedic, and he works as a clinical education specialist for 410 Medical. And we're so thankful to have these fine educators present to us all these amazing cases. So let's get on to it. Some tips for watching today. We want you to weigh in. The panelists will absolutely ask you for your feedback and your questions and comments. So feel free to type in the chat or unmute your mic and join us. We also, for today's episode, would love to hear what you've enjoyed about Real Emergency in the past. And we can share those once we get closer to the end of the episode. So we're going to get started with David presenting his first clip, and this is from one of our early episodes. David, if you can just kind of set up the clip a little bit before James plays it, then we'll give everybody a little bit of context. Over to you.
Well, first of all, before we get started, I want to say it's an incredible honor, Hillary, to work with you and Prodigy. And, you know, this has been an incredible organic experience over the last 2 years. And I've been a couple different organic processes, and this has been one of my most favorite things that I've ever participated in, and mostly because I got to meet people like you and James and Amy and Zach and Peter and Mark and Rob. And you know, one of the things is that I've learned is that everyone here is dedicated to trying to move the needle and support this incredible group of paramedics and EMS providers. And I just feel really, really honored to be a part of this process. And I'd like to start by just firing up the video, because I'm all about the video, you know that. So let's just fire up the video. We don't need to set too much up. And this is one of the first episodes that we created. And why don't you roll the tape?
Okay, so
I am.
So full body shaking?
Yes. Yes, this will be his third.
Does he take medications?
No. And I knew that his fever was getting up there, and I was trying to get back in the car.
Yeah.
I think this case exemplifies the issue of ABCs and the first things that you need to do. And, you know, we at ReelDx and a lot of the cases that we've shown have been around showing real patient video and sort of learning from it, and what we can learn from real patient scenarios of bringing people together like all of us who have seen some of these things and learned. I've learned so much since I've been here. One of the things I learned from that particular case is that it's really important to undress the child and look at a child's respiratory rate And obviously this was an extreme example where there was a red blanket over the child, but specifically with children, which gets everyone anxious if you're not just taking care of kids, and even if you are, children can be in respiratory distress or respiratory failure, and you don't know it unless you actually undress them. And, you know, one of the things we learned from an ATLS standpoint is that you actually take folks, you take their clothing off or whatever's on them to actually visualize what's happening. And a child in respiratory distress can can actually be subtle. So that's the primary point of that video. It should be really, really uncomfortable when you see that. And Peter, Mark, Zach, I don't know if you have any other thoughts, but that was the one piece from that case I really wanted to get forward. And the last thing I'll say is that today, I've been looking forward to today so much, because when I'm working with a resident for 8 hours in a shift, if they learn one thing in a shift, it's a complete victory. And so I'm hoping each of you can take away one thing from each of these clips. And the one thing that I want to share is that undress the child, take a look at their chest, especially if it's a toddler, young baby, infant, because you really can't assess them unless you actually get to expose their respiratory effort.
David, maybe tell us what you saw, since I don't know if we're going to watch the rest of that scenario, which I'd like to if we could, but what did you see, and how did the paramedics there respond?
Yeah, well, that child was actually turns out that child was in a complex febrile seizure. And it was unclear whether, when the child was undressed, whether the child was actually postictal or whether the child was actually actively seizing. And that was a lot of the discussion for that case as well. And a teaching point is that sometimes after a long seizure, whether a child's in status epilepticus or whether it's a complex febrile seizure, which this was, sometimes at the end of it, when a child is tonic, it's sometimes very subtle to figure out whether the child is actually still seizing or not. And it can be just a difficult thing to think about how aggressive you want to be with anti-epileptics.
I'm going to make a comment, because I think, what I love about David is that you're so focused on assessment. And I think that a lot of us kind of want to go to the cool stuff, right? But it's so important, especially in pediatrics, to focus on assessment. And so what I wanted to mention of this case is the fact that, and some of the mistakes that I see that are happening in the field, especially coming into the emergency department, is that the kid has a seizure, and let's say that they got a benzo, right? They got midazolam, and people throw on the non-rebreather, right? That's because what people do, here's a non-rebreather. And now the kid's breathing, I'm just going to make this up, 4 times a minute. And all of us know that 4 times a minute at 100% FiO2 on a non-rebreather, they're going to be 100% O2 set, right? And you wheel them on in, and you're looking at them on the stretcher as they're coming by you, and you see the kid's only breathing 4 times a minute, right? And the kid's unconscious, right? Because they're quote unquote post-ictal. And what passes by many people is that if they just would have put an end tidal on the kid, it would have been 60, 70, right? So also the waveform capnography will give you a respiratory rate, like it's the cheat code, right? You could see that the kid is only breathing 4 times a minute. So please use end tidal. It'll help you get to the simple stuff, which is, how are they breathing? Are they breathing effectively? What's their respiratory rate? What's their O2 sat? What's their end tidal CO2? And oftentimes these kids need an OPA. And if the OPA sits there, that means that, yeah, they probably needed that OPA, and then you can go ahead and bag those people. So I just wanted to reemphasize that what you're saying is very, very important. And I want people not to forget some of the basics when it comes to vital signs. End tidal CO2 may be the most important one.
Great. Let's move on to Peter's clip. He's going to present from a case that we had that was quite unique in that it was an end of life case where we had 911 response to a patient who was on hospice who had some altered mental status and some other issues. So James, if we could cue that up, and Peter, anything to add before we start?
Yeah. Yes, before we start, first of all, thank you so much for the intro, Hillary. This is a very important case to me. My father what was in hospice situation. Unfortunately, my dad had Alzheimer's. He passed away several years ago. May he rest in peace. However, I will tell you that there were a number of occasions while he was on hospice that my mom had to call 911. And what this case that you're about to see really represents to me is the fact that when you walk into a home where there's an elderly person who's on hospice, who has something terminal, it's very difficult to kind of start to tease, is this a patient who's in the dying process, who wants to be left at home, or is it a patient who is in hospice who happens to have an acute event that does require hospitalization? We don't do a good enough job of teaching this, unfortunately.
And before you play it real quickly, I want everyone to know, James, before you play it, that all the patients in all cases that we present here, folks are giving consent. I just want everyone to be very clear, if you're new to this, that all of our patients have had consent prior to playing. Sorry.
Thank you.
Can you do oxygen? Talk to them.
Moving air now. We got here, right?
I'm asking you. I haven't heard him take a breath yet again, so.
It's 12:31. What's his date of birth? Yeah. Dr. Holden's his doctor.
Let's get a glucometer out, check sugar, please.
H's and T's, but so glucometer's gonna be right here on Mark's backpack. He said that he had.
You did.
Is it a heart condition or anything?
Just take the bag out, whoever's digging it.
Pull it off him. Any stroke in the past? Diabetic? High blood pressure? Well, being medicated for it. Okay.
Lee. Hey, Lee. Lee's rate is narrow and in the 140.
He said he felt like he had heartburn, so I gave him a Tums.
So Darren,
Yeah.
it's unclear, comfort measures only, do they not want an IV? Anything like that? I just want to confirm with her.
Just to set that up, is that the wife was a teacher, and he was a teacher, and she thought that this would be a great opportunity for folks to learn. She pretty much panicked because there was some agonal breathing when there was supposed to be a hospice passing away at home, but these are really, really, really difficult situations. And I don't know, Rob or Zach, if you want to comment about this, but I still don't know what the right answer is in some level.
The question I have for Doc is, either any of you, is how do we educate without talking them into either not maybe performing care or not transporting, if that makes sense. So there's an education piece there, but it's also a fine line that we face oftentimes because we're battling the emotions and the intensity of the situation sometimes. But I found oftentimes just educating them that this is the natural process, this is the way things are supposed to happen, may be comfort to them and help us with maybe not transporting if that's not what they want. So just speak to that. What is that fine line, and how does that education piece look for them?
I'm curious to hear what Mark, as a critical care physician, thinks about this, because in some ways, the wife here is almost like a mother for a pediatric patient. She's the advocate. And I'm just curious, these are really difficult situations and difficult conversations to have, and especially from an EMS provider who doesn't know the family, and then all of a sudden they're put in that kind of situation. Really, really difficult. Mark, can you opine about that?
Yeah, I'd love to. I wish David, I can't remember how he was involved with hospice or palliative care at the time, so that might be helpful to know. But I guess what I was impressed with was the total calm, kind approach that these guys took. It was it brought everyone at ease, even us watching. And I think that there's almost 2 patients there. It was him and his wife. And I think, as I remember, the team turned to her, kind of got her input once they kind of done their basic assessment, and allowed her to, then it helped her make a more informed decision about what the next step was, which honestly, David, I can't remember what they chose to do, but I was just super impressed with the way, the compassion that team showed. They minimized intervention, maximized the calm, caring approach they took to her and to her husband.
When people call 911 when their loved one is on hospice, it's often because they don't know what else to do, right? That's sort of our lives, that we have to understand that people are absolutely panicked and they don't know what to do, and we're their safety net. That's what we do. Hospice nurses are available often when people are on hospice, but they're not available in the same way we are, that can be there within 5, 8, 10 minutes. I do urge you all, those of you who are struggling with that in your system, go look at some of the hospice programs that are being implemented with mobile integrated healthcare and community paramedicine, where they are being adjuncts to those systems and helping out with hospice, because hospice doesn't have the amount of personnel that they need. And all the experiences I've had, they're exactly the same as everyone's talking about in the chat, which is that there's a disconnect often between what the patient wants and what the family wants, and you're there to mitigate that. And it's an incredibly emotionally demanding situation. Peter, now that you're back, lots of chats about how difficult this is, but provide some insight for us on what you're thinking about.
Yeah, so there's 2 things. Number one, I put the paper in the chat, so read that. It'll kind of prime all of us for maybe what some next steps are. The second thing is, I think we need to do some simulation type activity at our departments to help figure that out. But I wanted to end with the most common call I get as a medical director. Hey doc, I'm on scene. It's a hospice patient, and in Florida, it's got to be like canary yellow paper, and it's got to be signed by the right people, the whole thing. It's never signed. It's never the right paper. It's never, never, never. So I made a policy about 10 years ago that said, if the patient's a hospice patient and you can confirm that, and someone says they're, if it's the right person legally, that this is my father, my mother, my brother, my sister, and they're a hospice patient, and the story sounds right and everything sounds right, it's just that the form is not correct, it's a call to me. I hear the story, and then I say, you're going to use my name as this is a functional DNR. People thought I was crazy. But I can tell you that there's hundreds of patients, because one of my systems, we deal primarily with hospice, it's a private ambulance company. And like I hear has been mentioned, people call at the 11th hour because they're worried that, oh my God, they're seizing or they're vomiting, whatever, and they get nervous. We have to be able to come in and respect their wishes if they're in the dying process. And we have to do more about that. So if you don't have a medical director to get involved, I would say try to get the medical director involved so that we can overcome the issues that all of us experience with these forms. So thanks.
Wonderful.
And Peter and Hillary, I just noticed in the chat, William said that they do a one-day ride along with hospice nurses each year. And I think that seems like an effective way to kind of condition yourself for these situations. So Peter, do your folks do that, or how do you feel about that?
We don't, but my private ambulance group, we deal with the hospice folks specifically. We've actually created our own protocols to go along with what the hospice folks do, which is very different than my regular protocol. I'm happy to share it. But Bill Schneiderman is a very knowledgeable man, let me tell you. So Bill, thanks for that comment. I love that idea.
Yeah, that's fabulous. Okay, Mark, we're going to head over to you for the next case, which is a pretty dramatic case of a gunshot wound. How would you like to set this up?
Yeah, so to one of my favorite topics, trauma resuscitation, and kind of the other end of the spectrum of what we were just talking about. You heard David mention focusing on the ABCs when approaching a pediatric patient. In trauma, we're learning increasingly that we need to focus on the CABs, like consider the important role of circulation first, both stopping bleeding and resuscitating before we actively manage or perform high-level airway interventions. And so this clip, or these 2 clips, illustrate that well. An expertly performed resuscitation in near Houston, Zach's a former agency actually. And James, if you would play the one clip first and then stop and we'll play the second one. I want to set it up. You've probably seen this before, but it was a gentleman shot in his garage in a home invasion, and you're going to first see the paramedics approach the patient in the garage, and then next we'll see him loaded into the ambulance.
Building's gonna be set up at the. Hi, so we have an infant thermal here going through. He has lung sounds. Blood pressure is 85/62.
Okay.
So do you see how what I'm thinking
I'm dying.
with the way that the gunshot wound is?
So just, I wish we could talk about this for a lot longer, but the scene is no blood, but a known gunshot wound, a small ballistic wound in the shoulder with breath sounds on the left, but a pressure of 85, and the patient says he's dying. So we know there's something bad, catastrophic going on inside. We don't know where the blood is. We don't know where the injury is, but we can obviously see there's something bad going on. And then James, if you'll go to the second clip.
99/60.
Perfect. So
Keep it on.
okay. We got another blood pressure going, 100/63. I am convinced that with the continued infusion of blood products that he will hopefully, and we can resolve his tension pneumo, he won't arrest.
This was actually a physician that jumped in the truck. And in the minutes before this, they had delivered a couple units of blood. They had opened his chest, drained a bunch of air and blood out, all in preparation for advanced airway management. The mental status had steadily declined. His blood pressure, I think, was in the 60s. Zach, you can nod if that's about right. And he was approaching cardiac arrest from hypovolemic shock. And to then put an advanced airway in that situation, despite his GCS of 3, risked a cardiac arrest in that moment. And so that the team was effectively able to resuscitate with blood, actually whole blood, and get his systolic in the hundreds. I think he got calcium as well. He got his chest opened, and then he was expertly pre-oxygenated and intubated and whisked off to downtown Houston, where he went straight to the OR and walked out of the hospital later after repair of his internal thoracic wounds. Fascinating story illustrating the CAB concept.
Yeah, I mean, everything kind of had to go perfect for this guy. A couple of things that, there was a hospital that was about 3 minutes away. It was not a trauma hospital, right? So there's still that argument across the country to get him to the hospital as quickly as possible. I would argue that he got clearly effective pre-hospital care. Everybody did their job how they're supposed to. Interestingly, not just that he got blood, but he got blood quickly. He got several units quickly, and then was able to be resuscitated, as Doc said. So just one of those things where everything had to go right, but it was also something that had been rehearsed, practiced, and everybody was on the same page ahead of time. So there was never any chaos or confusion about what was going to happen on this case.
I have a comment, and I want to just mention here that from the time that we recorded this episode the first time, which was our very first episode, until today, the world has changed. And you, Mark Peel, have had a big influence in that. So thank you very much. So we now in Broward County have blood, thanks to Dr. Jim Roach and Heath Clark. We have it in Palm Beach County, thanks to my amazing leadership team and my fire chiefs. And I can tell you that people thought for a long time that, oh, we're so close to the hospital, let's just let them do it. That's completely wrong. So we, thanks to Mark and the life flow, we are able to give a unit in a couple of minutes. And our data is staggering that if you got the blood before you got into cardiac arrest, there's a 90% chance survival, including an officer who was shot in the groin, and he had a hole in his groin about that big. He was bleeding out, he was unconscious. And before we took his airway, as to Mark's point, my EMS captain said, let's give the guy blood first. We gave him a unit, the guy wakes up and he says, give me more. My buddy was the trauma surgeon on that case, and he calls me up afterwards and he says, this is incredible. And so there's a huge tidal wave of whole blood happening across this country. Mark, it's because of you, it's because of people like CJ Winkler, Randy Schaefer, and many others. And so, Zach, the fact that you had this on video, this video changed the world, my friend. So thank you so much for what you guys do. This is crazy.
I think the take home is effective resuscitation in a critically injured patient can dramatically change their outcome and save a life, even in a few minutes. So it doesn't have to delay transport. And I think they showed that. And there's a lot of data now that are showing that. So
Mark,
Yeah,
if you
I'll
can
stop
put
there.
any info into more whole blood data in addition to what you've already done, go for it. But
Can I
Okay.
just say one thing? I just want to thank Mark for his leadership because, one of the things that drew Mark and Peter and I together initially was that we all started companies and started doing things in ways to actually push the needle. And I really appreciate Mark's
Hello?
recognition of the fact that he saw things clinically and took action on it and actually has developed national leadership and pushing the edge of getting blood products earlier. And this video and the work that Mark has done with his group is really pushing that needle. And thank you so much.
So I'm an EMS chief in a very, very rural part of Montana. Some of our transport times are 45 minutes to the closest critical access hospital. Montana does not allow us to do any RSI. So in this situation, other than calling flight, which we have a trauma facility by air 20 to 25 minutes. And I've coached all my people on, as soon as we hear the call, we pretty much know then, launch it then. It's better to have it and cancel than to be behind the ball. But so in this instance where we can't RSI, we're so far away, do you have any other recommendations for us? Because we don't have any assistance. The fire department is all volunteer. So usually you've got a driver and a medic that respond. So we're
So I'll put in one thought and then I'll let the others. But one thing we're showing is that if you resuscitate, and if you're talking about trauma, if you resuscitate, you may not have to intubate. We actually are about to present those data that people that got blood earlier may not have even needed an RSI. They may not have even needed an advanced airway. I think, Peter, you're seeing that in Broward as well. I don't know how to help you with changing the law in Montana to allow you to have RSI protocol. What does anyone else think?
I can tell you that I just got hit up by the state of Colorado, and they said that based on what we're seeing happening in Texas and Florida, the state of Colorado is going and they're creating their own whole blood mechanism for everybody in the state. This is what it has to come down to. We have people at the federal government level who are reaching out to me who are saying, we have to make this happen on a federal level. So it's coming. It's going to come your way, whether you like it or not. So I would say instead of you working on at your own agency, which sounds rural and it sounds like it's a big task, start from the top because that's where the money is and that's where the structure can come in. And then the last thing I'll say is, please join the Tulane registry if you have a blood program, because someone asked about data in the chat there. All of our data now goes to one registry. This is going to be like the CARES registry for cardiac arrest. They have the Tulane whole blood registry. Please send the data in, because the data that Mark's involved in getting, and I know he can't tell some of the data because it hasn't been published yet, but it's mind-blowing. And it's going to
Peter, thank you for that. I put that in the chat. We've had a few people say we're not allowed to give blood, and it seems like the two things that prevent this are cost and availability and kind of maintenance. One of the things that a lot of you will say is that you don't have either a cooler to keep the blood cool or a warmer to give warm blood. And there are lots of agencies around the country, look at New Orleans EMS, who are doing things with blood that don't use coolers and don't use warmers. And it still seems to help. The initial data says that. So we do need to move on to our next case, which is a bit of a pivot. So Zach, we're going to go over to you for anaphylaxis, and go ahead and set us up.
Yeah, so this one basically was an anaphylaxis reaction at an allergy clinic of all places. I remember sitting there getting the call as a colleague of mine was telling me about how he had just returned to work from an anaphylactic reaction, being that he had to be intubated on, so that it was very ironic. And we got there, and as you'll see in this first part, this patient is very, very sick. He's in severe anaphylactic shock. And so we'll go ahead and play the first clip.
And 3 rounds of epi.
Okay.
0.3 times 3. Neb treatment.
Is that just albuterol or?
Just albuterol.
Okay.
Okay.
All right.
His O2 sat is
61.
61 right now?
Yeah.
Okay. Let's go ahead and clear the stretcher. I'm going to try and.
So as you can see here, he's already had 3 epi. His O2 saturation is 61. This is what I call a bad day. and he's laying flat. So the crew immediately sets him upright and then starts aggressively resuscitating with CPAP, a lot of positive pressure. I think they put the PEEP to 10. More epi. Technically, if you're going by your guidelines and protocols, he's already had 3 doses of epi, right? So, but it would be insane to not give more epi. So they hit him with IM, then they gave push dose epi, and then started him in an epi drip at 10 mics, and he ended up turning around.
Hypoxia is a pulmonary vasoconstrictor, and pulmonary vasoconstriction is the afterload to the right side of the heart. And so there is, correcting hypoxia aggressively is also a way to reduce afterload on the right side of the heart and improve like forward flow through the system. And so there is also lots of things at play, but potentially also a hemodynamic benefit to doing that.
Good point.
But what I love about that is that it goes back to the theory of ventilation, oxygenation and ventilation have probably more to do with flow than anything else, right? So opening up those lung beds, by relieving the hypoxia is a critical thing in this case, and also in cases of cardiac arrest. So I love that comment, and hopefully people take that one to heart.
A little bit thumbs up or worse? Okay, good.
So to give some context there, what Dr. Dorsett and Dr. Handtevy were talking about is one of the main questions came from this case is this guy was obviously hypotensive, requiring aggressive resuscitation with epi, Benadryl, and then he needs to be oxygenated as well. So being hypotensive, do we still give high doses of PEEP? And so that's what Dr. Dorsett was speaking to, is we have to oxygenate this patient. We don't sacrifice oxygenation due to hypotension. We can fix that with pressors. We're obviously giving epi. If you've given epi, give more epi. Dr. Handtevy talks to that as well. Most protocols stop at about, after that 3rd dose, you stop. But it's not always that simple and easy. And I would argue in this case right here, most of us don't see these patients turn around. And that's what was unique about him with aggressive resuscitation early on. I went out to the ambulance to get everything ready to go to intubate this guy. And by the time he got out there with multiple epi-IM, epi-drip, combi vent, Benadryl, he was starting to open back up and give the thumbs up as you saw there at the end. So he actually turned around and avoided intubation. So what comments do you have, doctors?
Well, I have a comment. I see Magdalena says, I said push dose epi for everyone. I joke because I love it so much. And she says, I wish we only do drips. I would get rid of the drips. In my area, we're so close to a hospital that by the time we set the drip up, we're already there. So push dose epi, if you know how to do it, should take about 15 seconds, 20, 30 seconds maximum. And so I was on scene recently of a guy who was having a stroke. He was hypotensive. We gave push pressure epi. We ended up, we tubed him. We put an OG, 2 IVs, got to the ER. He was in the CT scanner because the ER had nothing else to do. He had a large vessel occlusion. So were it not for the push pressure epi quickly, a mile before we got to the hospital, it was only a mile away. So this thought about epi drips in EMS needs to be a secondary thing. Push pressure epi needs to be in every EMS protocol, period.
And I'll just say for children, bring it back to kids with anaphylaxis. Oftentimes, I think we underdose with epinephrine. We often give it sub-Q, and after a few minutes, if a kid is still in distress, whether it's wheezing, whether it's diffuse urticaria, whether it's angioedema, after a few minutes, with the maximum dose sub-Q that we give in the ED, I just repeat the dose. I repeat the dose every few minutes, and then all of a sudden, magic, symptoms start to resolve. It takes Benadryl and some other meds and steroids, of course, a longer time to work, and epinephrine is just gold. And I think we oftentimes underdose it in cases of anaphylaxis, including in the pediatric population.
No doubt.
And it's worth remembering that any drug that comes in drip form has a short half-life, which means once you give a dose, it's gone. The half-life's less than 5 minutes, so it's gone. That epi is gone. So redosing just is almost like giving a drip, as Peter said. So using the push dose, I think, is valuable. And as Zach said, this guy had already had 3 injectors, but that had been well more than 5 minutes before you got there. So I think he deserved more.
And I'm gonna one more comment that I think people get nervous about epi on. If I give all of you 1 milligram of epi, 1 to 10,000 cardiac arrest epi, all of you end up in the cath lab. It hurts all of you. That's why giving epi to people with a pulse kills them. But if I took 10 mics of epi, right, which is just push pressure 1 ml, and I gave it to you, it's like coming to Miami and having a cup of Cuban coffee, a little cortadito, okay? So it's harmless. It's harmless. So you can give 1 ml, another ml, another ml. It's not going to harm anybody. So it's safe, it's effective. You can titrate it by giving 1 ml at a time. This is what we need to do, and there's good data on it.
And here we have Dr. Marvin Wayne. In Europe, they start with 0.5 milligrams. Physiologically makes more sense. And he says anaphylaxis is epi deficiency disease. Who knew?
Right, but I'm gonna comment to Marv. So 0.5 milligrams is 500 micrograms, right? So that's still a pretty juicy dose, Marv. I get it. And so if you look at what the American Heart Association says, it says to use 0.1 milligrams, which is a small dose. But what they don't tell you is to give it very, very slowly. So they kind of miss this whole dilution. And the only way to give that epi to an alive patient is to dilute it first. There's no prepackaged epi that is appropriate for the alive patient. So you have to make the push pressure yourself. Again, it takes about 15 to 30 seconds.
Great. Let's move on to a few more cases. We have coming up next, David talking about a case from kind of a pediatric potpourri that we did. So David, go ahead.
Yeah, just again, this case is take a look at the clip that you're going to see now and what makes you feel uncomfortable when you take a look at this clip. So roll it. This is a infant presenting with abdominal pain or some sort of pain crisis to the mother.
All right, so we're here today with Allison's mom. This is Allison. She's not feeling very well right now. Mom, can you tell me what started today?
She had been fine all day, and then all of a sudden she would have bouts of it was kind of like she was throwing a temper tantrum. Mm-hmm. She could tell she was in a lot of pain and something wasn't right. And she had been having a lot of bowel movements throughout the day. So that's whenever she was in a lot of pain is when I decided to bring her in.
Was she constantly in pain, or did it come and go in kind of episodes?
It would come and go in episodes. She would be able to be soothed for like a few minutes, and then she would just start screaming again.
Okay. And how old is she now?
She is a year old.
Okay.
Okay, so we just played 10, 15 seconds into this. Is this child sick or not sick? Is this child someone that you're extremely worried about right this second? Are you not? Thoughts, comments?
David, what time of the day is this? Do you happen to know that?
Yeah, it's 11 a.m. So her sleep pattern is completely off and had a really difficult time sleeping the night before.
Okay. Yeah, because one of my golden rules in the emergency department is no one ever leaves my emergency department asleep.
So I think the learning point there is that child was not right. And I know everyone on this call understands this, but for a child this age, the parent is the proxy, and parents know their kids for the most part. And I always listen to the mother. When the mother's concerned about a child, that gets me concerned. And if you saw that child in that position, which is prone with the legs flexed like that and just sleeping like that, that's a classic position and concern for an abdominal intestinal obstruction, which we call intussusception. So imprint that in your brain. You shouldn't forget that's a concern, and that needs to be transported. So I don't know, Mark, Peter, if y'all have any comments about that.
No, I mean, that's a perfect example of an intussusception. So the child, I describe these children as having apathy more than lethargy. And I think this one was asleep too, but just didn't care about what was going on. Bright room, new provider, and laying with the legs tucked up after bouts of abdominal pain. That is intussusception. It's a bowel obstruction. It needs to be treated quickly.
And I think when a mother states that she's concerned about the change in the mental status of a
Absolutely.
child, you just pay attention to it. You just
Absolutely.
don't, because you could look at that child and say, oh, that child's sleeping. But when the mother says in the last 24 hours, this child's not been acting right, that's the teaching point. Pay attention to that.
The comment I'll make on that is that if you walk into the home and the kid looks relatively, or it's nighttime, the kid looks okay, and you automatically think like, you just woke me up and your kid looks pretty good. And all of a sudden you give the mom the vibe that like, why did you just call 911? She will never give you the information that you need. And the history that you should have taken and the questions you should have asked, she's just cursing at you on the inside. And so I always tell my folks to always be open and always tell the parent, I'm glad that you called. Then the mom says, oh, I like this person. I knew I should have called. And then they'll give you all the information that you needed to make this diagnosis, which is not so easy to make.
Yeah, I would say the last thing I'll say is that a lot of parents come in and their kid is fine and they're like, oh, I feel so bad you're coming to the ER today. And, you know, I always reassure them and say, I'm so glad you came in because I got to meet you and whatnot. I'm giving parents the benefit of the doubt, and I'd rather they come in if they're anxious or concerned because God forbid they have a problem like this. I want to be able to take care of it.
And David, Mark, Peter, Zach, you guys have to know how valuable your human factors training is for us as well. Leanna has just chimed in to say, as a parent of a special needs child who has a trach and a G-tube, I cannot express strongly enough that parents know their kids. And you guys are giving us the tools to talk to parents correctly. Really quickly though, I don't even like to say it, much less spell it, but David, quickly, what is intussusception exactly?
Really good word. It's a really good word. And unfortunately, it's too long to play in a Scrabble, a regular Scrabble game.
Way too many S's.
But intussusception is when the intestine involutes on itself and actually causes an obstruction. It becomes swollen and then with peristalsis that causes pain and discomfort. And it's actually an obstruction that needs to be resolved. Thankfully, 90% of the time it can be resolved with what's called an air contrast enema, where you blow air through the rectum and in the radiology suite, and oftentimes it can be resolved. 10% of the time that doesn't work, or it recurs, and a child would need surgery. But most of the time, these children can go home and we can solve the problem.
Wonderful. Thank you. All right, Peter, I think we may be ending with your clip and then asking our audience what they want to talk about. But you've got a great idea here for airway management. And it's good that we have Dr. Wayne on board as well.
Yeah, so I want to clarify what Dr. Wayne mentioned on his the 0.5 milligrams. He was talking about intramuscular epi. So yes, a lot of people would agree with that. I was talking about the IV form. So Marv, thank you for clarifying. So Dr. Marv Wayne, if you don't know him, is just an incredible human being, an incredible ER doctor, but maybe even the best EMS medical director because he's on scene. This clip may have gotten the most traction of any clip that I've ever used, which is they were on scene for a fire. There were 4 patients, 3 of them needed to be intubated, and 1 was a child. And that child received a 4.0 tube on scene when they really needed a 6.5 tube, right? A 6.5 tube. So that tube was placed on scene. They decided to not change it out until you got to the emergency department. That was about a 20-minute difference. So why I want to show this clip is that you'll see the arteriorytenoid folds really swollen just 20 minutes later. And therefore, it's to impress upon everybody, do the right thing on scene, intubate on scene if you have to, because once you wait, it's too late. But you'll see a very interesting corkscrew technique. I want Dr. Wayne to talk about it afterwards. That he actually let his medic in the emergency department re-intubate this child. So let's play the clip and hold on to your seats for this one. So this is the re-intubation. They just pulled the 4.0 tube, and the first thing that comes into view right there at the bottom are the arteriorytenoid folds. That's what swells up in a burned airway. Those were not swollen 20 minutes ago. And now we have a cuffed ET tube, 6.5, 6 or 6.5, I'm not sure. And if you put anything smaller in here, there's no way you'll be able to suction anything out of this kid's lungs. You kind of needed this size of a tube. So what you're going to see is that, you know, you had Dr. Wayne over this guy's shoulder saying, okay, corkscrew it, just put some gentle pressure. And you'll see here, there's the corkscrew to the right, because it's a beveled ET tube. And then right about here, as your heart is somewhere in your abdomen, Boom, there it goes. And so this kid had a great outcome. And so Dr. Wayne, Mr. Legend, and soon to be having a big birthday, my friend, welcome to the show and give us some comments.
Hey, Peter, can you guys hear me?
Yes, sir.
Yeah. Hey, first of all, thank you for the privilege of being on 2 of your shows. And I do consider it a privilege. Peter, you're as a Yiddisher, we would say you're a mensch. You've done so much to make lives better. I just annoy people. Hey, seriously, I do that too. So this was a early morning call. Flamer actually was around us, so they kind of beat it down, and we really were working the back. I had a student and 4 other medics with all these patients, and I didn't look over the shoulder on the intubation. The small tube actually fell out, and it was not that we pulled it. I promise you, we would have not pulled it. We would have used that to continue to oxygenate. So what we did is the best we could, high flow nasal, and this is the result. And we had all these patients. So I took one of them, which was this little kid. And there's a lot of things. This call occurred several years ago, and I kept it for a while because of medical legal reasons to make sure everything was clear with the family and all that. The key I would go back to what Peter said. Burned airway is an airway disease, okay? Or inhalation injury is an airway disease. Whatever other this external burns the patient has, the one that's not, those aren't going to kill the patient unless there's other trauma immediately. What's going to kill them is hypoxia and hypoventilation. So this is a scary situation. And we had 3 of these. We had mom with groomas pouring out of her airway. We had the 13-year-old, and this was the 10-year-old. So just again, this was an error, even with the doc there. I couldn't watch all of them. And this is, I hope people will watch the full Real EMS of this, because I think you, Bryce, brought up some amazing points. No, we didn't do a lot of things that we would do better today, but it shows the contrast. So thank you. And again, as always, I'm privileged to have the pleasure of working with and harassing Peter, because he is in many ways my idol, even at my senior age. And the other thing is, we're struggling to put the blood program together. It's strange because EMS is 100% on board. The blood system is on board. And we have a hospital, which is the only hospital in the area, which is a level 2 trauma, that doesn't understand what whole blood is.
Well,
but thanks again, guys.
Marv, it takes leadership to actually show people a case that you feel could have gone better. So thank you for doing that. And thanks for your leadership in EMS. So Hillary, back to you. Let's open it up.
Okay, so I heard earlier in our chat from Rita, who talked about the anaphylaxis case. And Rita, if you're comfortable, either in the chat or if you want to unmute, what did you learn from that anaphylaxis case? Because you mentioned it early on in our session today. Did something change your practice, or when you watched it, what struck you?
It's more like getting that word out there, because we have a battle working through the state to get push dose pressors and see the need for repetitive doses of epi and things like that. And to have a case where you actually show that is so beneficial, to pass on that word and bring that to light to so many people. And that's what I liked about that, because not many people get to hear about that. You get to hear about the anaphylaxis and a dose of epinephrine and you're good to go. So having that case was beneficial to have some discussions, and I'm hoping that we're getting it into a couple of our guidelines on the critical care side. And I hope that we have a epi drip now, but I'm hoping that push dose, melts into those protocols a lot better with the coming year.
I had a tragic case recently where an adolescent with a nut allergy ate a bunch of nuts inadvertently and had a severe anaphylaxis and refused the EpiPen for 20 minutes because she was scared of it. And I understand that in that scary situation, but she ultimately died. And it shows the value of early and effective treatment of anaphylaxis. And so I guess I would just emphasize everything you guys have already said. Early treatment makes a difference in many diseases, but particularly anaphylaxis.
When you look at the data on epi in EMS, for anaphylaxis, it's very low. And there's a lot of studies out there that show that. I even heard of one agency in California who wants to take away Benadryl just so that the medics only have one thing to give, which is epinephrine. And so, I mean, like, it's kind of a weird thing. It's like when someone asks you, where's your left ear? You do this. I mean, it doesn't make any sense that you would pull off Benadryl. Just give the freaking epi. That's what I would say, and give it first.
Yeah, I've heard that too, Peter. That's not the first time I've heard that removing the Benadryl would lead to more epi. Yeah. Great. We have Aubrey Wright, who talked about her department really enjoying the pediatric videos. Aubrey, I don't know if you're able to unmute and tell us what you've done with them, but for Aubrey or anyone, have you used these in your training? Have you showed them in a group setting or in a classroom? And if so, how and what tips can you give us and your fellow viewers today?
Yeah, I'm Aubrey. We are in Central California in the middle of the national forest. And we do have camp here. And so we run about 2,000 kids here on camp weekly in the summer. And so pediatrics is big for us. We're an hour and a half from any local hospital. So all the the Reel videos have been incredible for our team. We actually sit down twice a month and kind of walk through some of those videos. We do other stuff too, but then we do like real life scenarios with some kids who live here and just kind of play them out and help our EMTs just know what to do and how to do it well. So you guys are incredible teachers for us, even though it's not live, but it's pretty incredible. So thank you.
Love it.
Sounds like a beautiful place. Maybe we can do a live Reel emergency from your camp.
Hey, we would not be opposed to that. You are more than welcome.
I mean, you basically, Mark, you're basically saying like, we'll have 2,000 kids. You just go sit there with the camera and wait for somebody to do something silly.
Exactly.
It happens all the time. Don't worry.
I'm going to jump in, guys. The good Dr. Handtevy, I know, is a camp doc. There's a webinar / podcast / video in there. I think there's something we need to do one of these actually.
I was about to say, I do 4 weeks a year at a camp because my kids go there, and I spend time up there. And I think I see like 1,000 kids a day. I'm not sure why they keep coming to me to put cream on their hand. I'm not sure what it is. A mosquito bite. Yes.
I just want to, before Hillary sort of wraps it up, I just want to congratulate everyone on EMS week. And I'm honored. I'm a former paramedic, and it's been an honor to work with Mark and Peter and Rob and Prodigy. This has been just such an incredible experience. I think all of us are excited to bring you more. This is sort of our anniversary opportunity to sort of give you a potpourri, but I think we're dedicated and excited about bringing more interesting content to you all, and would love feedback. But I just want to say, guys, how this has been an incredible ride, and want to continue the journey with you all. And thank you for including me in this ride.
And how about this? We should also ask people, if you have videos available to you, please send them our way, because we need those. David has a huge library of videos in ReelDx, which if you haven't seen that, you should take a look at it. It's a great educational tool. But we're going to selfishly ask for more of your videos, that if that's possible.
We can't say enough how much of a thrill we get out of these episodes. All of us hang up and keep talking about it for days. So you guys are keeping us going, and we applaud you for your efforts and your time and energy here as well. Thanks for joining us. Look for us to come back in July or early August. And again, happy EMS week.